Hey classmates, in the next 10 to 15 minutes, I'd like to give you a brief overview of the acceptance and commitment therapy, also known as ACT. Before I signed up for this, I did not have a clue as to what this approach was about at all. It turns out it's incredibly aligned with my own undeveloped view of therapy. So, our society, we have learned that if you have suffering or pain, then there's something wrong with you and you need to fix it, or it needs to be solved. And ACT has a completely different approach. The ACT approach views suffering as not inherently bad, but rather that it's a common human experience that can be tuned into for its wisdom. So the objectives for this presentation, you're going to learn a brief history of ACT. Then I'll go over the theory and the technique, and finally I'll apply it to mental health disorder and investigate what the evidence says. Dr. Stephen Hayes is a clinical psychologist. He developed the acceptance and commitment therapy using his own relational frame theory, which I'll get into in a little bit. It was developed in 1982, and it was aimed to create a mixed approach which integrates both cognitive and behavioral therapy. It's one of many types of CBT that focuses more heavily on the processes such as acceptance of thoughts and mindfulness. Dr. Hayes proposed an existence of a third generation of CBT represented by therapies that have been developed during the last 20 years that emphasize the role of acceptance and mindfulness. Other therapies that fall under this third wave include DBT, mindfulness-based cognitive therapy, and functional analytic psychotherapy. I also wanted to mention one of the main controversies with ACT, and that is it seems to be quite similar to the Morita therapy developed around the early 1900s by Shoma Morita, which also focuses on acceptance of the situations, cultivating awareness, and honoring the rhythms of the environment. ACT uses acceptance and mindfulness strategies together with commitment and behavior change strategies to increase what they call psychological flexibility, which means being in the present moment as fully as possible and then changing or persisting the behavior given your set of values. The acronym ACT refers to the key steps involved: accept, choose, and take action. Experiential avoidance is a concept Dr. Hayes described as trying to avoid negative experiences directly. For example, humans will try to forget about past traumas or will try not to feel anxious in situations that lead to anxiety. All of these processes substantially increase the human capacity for suffering. Examples are like avoiding bodily sensations, avoiding emotions, thoughts, and certain memories. And it takes steps to try to decrease the form, the frequency, and when doing so, causes psychological harm. He states that the more negative events are avoided, the more they tend to occur. To better understand this concept, we can think of the Chinese finger trap game, where one places a finger inside the device, and the more one fights and struggles to remove the finger, the more stuck it becomes. So the antidote is to relax and to push the finger back into the device, thereby loosening it. This is exactly how ACT works, by leaning into the negative experience and try not to run away from it, thereby loosening the grip suffering has on an individual. There are six core principles to help clients develop psychological flexibility. Acceptance. Acceptance involves actively embracing inner experiences instead of running away from them. 2. Cognitive diffusion. This can be thought of as reducing the literal meaning of inner experiences so that the thoughts are experiences just as thoughts. Feelings are just feelings, and bodily sensations are just bodily sensations, and not putting any meaning to them. Being present is when we experience events in our environment as is occurring now, as opposed to focusing on the events in the past or the future. Self as context. The conceptualization self is the you that is constructed, that is based upon self-evaluations and categorizations. It is what we believe ourselves to be. The clinical issue is that people will attempt to protect, retain, or shield that conceptualization of the self, even when it leads to ineffective action. Values. Values are often contrasted with goals. Goals are obtainable, such as getting married. Values can only be instantiated as an aspect of ongoing action, such as being a loving and kind spouse. Thus, are more like adverbs than nouns. They can be pursued across one's life, but they cannot be possessed like objects. ACT works on getting to know one's personal values and then lead their life according to these values. And finally, this comes right into committed action, and that is the continuous redirection of behavior that matches a certain named value. The theory upon which ACT is based on is called the relational frame theory, and it's a big word, big theory, but basically you can think of this as our strength and our struggle come from the same source. Our ability to do really cool things, like make a pretzy presentation like I'm doing right now, and talking about abstract ideas over the internet and broadcasting them to you, these are our strengths. It's the same processes that causes us to suffer because we are able to create relationships to the events and ideas. So if I went to the garden store and picked up some tulips, and on my way home I was in a car crash, and now there are tulip petals scattered all over the floor, all over the car after the crash. I could relate the tulips to the car crash and start feeling scared and anxious whenever I see them. And this is often unconscious. We might not know why we're feeling anxious when we see the tulips. Essentially, there's no delete key from our experiences, our social conditioning. So for example, finish this phrase. Twinkle, twinkle, little. Okay, I'm pretty certain no one said diamond. This is partially why inner experiences are addressed with acceptance and mindfulness strategies. We accept that we all said star and not try to change this conditioning. According to Dr. Hayes, ACT is particularly helpful for people experiencing substance abuse, social withdrawal, agoraphobic avoidance, ruminative worry, and obsessive-compulsive behaviors, and other mental health issues where there is experiential avoidance. However, it did take a while for the evidence to build support for ACT. Finally, in 2012, a systemic analysis and meta-analysis was conducted looking at 16 different studies comparing ACT to CBT, which we know is a highly effective treatment, and concluded that 11 of the 16 studies found that ACT outperformed CBT, especially in depression. In 2015, a meta-analysis also found that ACT was more effective in treating anxiety and depression and substance abuse disorder than placebo. Despite the known effectiveness on anxiety and depression, I chose to look at something a little more specific, ACT as a therapy with people experiencing eating disorder. A recent study in Sweden looked at the effectiveness of ACT with people experiencing body image issues and exhibiting eating disorders. So people that had food restrictions, binging, purging, compulsive exercising, etc. Some participants received 12 sessions of ACT after being diagnosed with an eating disorder. At the 2-year follow-up, patients who received ACT showed a significant greater reduction in eating disorder symptoms and body image problems. Another study comparing ACT and traditional CBT for the treatment of disordered eating found that ACT was the more successful treatment. The results indicated that CBT did produce modest decreases in eating pathology, whereas ACT produced larger decreases. So they both worked, but ACT worked slightly better. One theory on why this works so well in this population is due to their high experiential avoidance and attempt to control an aspect of their life. An ACT-based treatment would attempt to disrupt the pattern of hyper-focus on the body and eating behavior. So DSM-5, what do they say about eating disorders? So the diagnostic criteria for eating disorders, this includes rumination disorder, avoidant or restrictive food intake disorder, anorexia nervosa, bulimia nervosa, and binge eating disorder. It results in a classification scheme that is mutually exclusive. So the practitioner must assign only one of these disorders to the client. However, it is understood that the underlying process remains similar in all of these disorders and therefore has been mostly grouped together when they're doing the research trials. The differential diagnosis includes other medical conditions such as GI diseases, hyperthyroidism, malignancies, and HIV. Also consider depression and anxiety, schizophrenia, and borderline personality disorder. Epidemiology. The prevalence of any eating disorder in America total is 4.6%, but an overall prevalence is 8.4% in women. According to the National Association of Anorexia Nervosa and Associated Disorders, at least 30 million people of all ages and genders suffer from an eating disorder in the US. Eating disorders are frequent in adolescents and even more in young adults and sometimes severe. They may lead to multiple psychiatric and somatic complications and are likely to have an impact in terms of quality of life and even mortality, according to Smink and colleagues. The eating disorders have the highest mortality rate of any mental illness. Is most present in the post-industrialized high-income countries. The incidence appears low in Latinos, African Americans, and Asians in the US, but this might not be accurate because the access and the utilization among these groups are also lower. According to Marquise and colleagues, eating disorders affects all races and all ethnic groups. One screening tool that I found useful is the SCOFF. This is a 5-question tool to screen for an eating disorder. It's similar to CAGE in that it quickly screens your client to see if further questioning is needed. So S, do you make yourself sick because you feel uncomfortably full? C, do you worry that you have lost control over how much you eat? O, have you recently lost more than 1 stone in a 3-month period? I actually had to look this up. I was certain they were not talking about kidney stones. 1 stone is equal to 15 pounds, so you can think of 1 stone or 1.5 pounds. The other one that gets me is the next one, F. It's a little insensitive. Do you believe you are fat when others say you're too thin? And I personally would be really careful about the wording here. Maybe use overweight instead. In that case, the acronym would be changed to SCOOF, or maybe just ask instead, where is your ideal weight compared to where you are currently? I had issues with that one, as you can see. F, food. Would you say that food dominates your life? Okay, moving on. Treatment. Treatment in some cases require hospitalization. Both individual and family therapy is recommended. CBT, dynamic psychotherapy are recommended by Kaplan and Sadak, and now there's sufficient evidence to recommend ACT as well. The symptoms of many individuals appear to diminish with or without treatment, although treatment clearly impacts the course and duration. Thank you so much for tuning into my presentation. I can tell you that I had to dig into my own set of values to be able to literally put my face out there to you all. My value? Connection. I value connection, and what better way to connect to my classmates than to make a video for you all. My questions are going to be posted in the forum. I'm also going to post the references there as well. Please give me some feedback, and thank you very much.